Next case is an example of palpitation with normal ECG. A patient presents with episodic palpitations and hyperventilation. However, a resting ECG is normal and the heart rhythm is regular. What is the most appropriate next investigation? If the resting ECG is normal and the heart rhythm is regular, the most appropriate next investigation is ambulatory ECG or Holter monitor. Ambulatory ECG or Holter monitor is the correct answer. Why? Palpitations are often paroxysmal. In this case, the palpitation is episodic or paroxysmal. So Holter monitoring helps to correlate the symptoms with the transient arrhythmias. So Holter monitoring can help to correlate the paroxysmal palpitations with the transient arrhythmias. Why the other options are incorrect? Troponins assesses the myocardial injury, not the rhythm. Echo evaluates the structure, not episodic arrhythmia. Chest X-ray adds little diagnostic value. Stress testing is not the first line. Let's start talking about two common causes of arrhythmia. This is the first one. Arrhythmogenic right ventricular dysplasia. Arrhythmogenic right ventricular dysplasia. On CT angio, there will be increased right ventricular trabeculation and intramyocardial fade. So the dysplasia of the right ventricle is caused by the increased intramyocardial fade of the right ventricle, along with increased trabeculation and dilatation of the right ventricle. This is the cause of the dysplasia. The muscle of the right ventricle is replaced by fat. On MRI, T1 weighted image with fat suppression. There will be right ventricular outflow tract dilatation. Okay. Transmural or islands of fatty infiltration of the right ventricle. That darkens with fat saturation with diffuse thinning of the right ventricular myocardium. Diffuse thinning of the right ventricular myocardium with transmural infiltration of the right ventricle with fat. So here this is the T1 weighted image and this is the T1 fat set image. This is the right ventricular myocardium. This is a delayed contrast image. So, sorry, this is the, yes, this is the T1 weighted image. As you can see the fat here, and this is the fat side image. The fat signal is attenuated here, suppressed here. So there's thinning of the right ventricle with delayed contrast enhancement. Delayed contrast enhancement on the delayed contrast on dynamic MRI. This is the delayed contrast enhancement. Okay. So here, this is the thinning and the infiltration of the right ventricular wall with fat of high signal. Okay. With delayed contrast enhancement of the affected myocardium, findings can affect the left ventricle. Can you see this one and this one? This one and this one. So the fat infiltration is seen in the right ventricle here and also in the left ventricle. This is the normal myocardium on T1. This is the fat infiltration. The fat infiltration. The fat infiltration on T1. And these areas will show delayed contrast enhancement. Delayed contrast enhancement. Delayed contrast enhancement. So this is arrhythmogenic ventricular dysplasia of right and left. Arrhythmogenic ventricular dysplasia. Also known as arrhythmogenic right ventricular cardiomyopathy, pathologically due to fibrofatty or fatty replacement of the right ventricular myocardium. The fibrofatty infiltration will lead to fat signal and the delayed enhancement of the myocardium. Presentation is serious ventricular arrhythmia, tachycardia with left bundle branch block, biventricular heart failure. So there will be ventricular arrhythmia. Management, medical treatment, antiarrhythmic drugs. Antiarrhythmic medication is the first line of treatment. Antiarrhythmic medication. If medical treatment fails, catheter, ablation. After the medical treatment, or if the medical treatment failed, implantable cardioverter defibrillator are used if there is a high risk of sudden death. Surgical treatment, cardiac transplantation is the last resort. Medical, implantable cardioverter defibrillator if there is a high risk of death, sudden death, and surgical. This is another case of arrhythmia, common cause of cardiac of cardiomyopathy to cause arrhythmia is called left ventricular non-compaction. So the first one was in the right ventricle, right ventricular dysplasia. Here, this is the left ventricular non-compaction. Apical and mid left ventricular. So the left ventricular non-compaction, common location apical, mid left ventricle, and also involve the right ventricle. MRI finding, ratio of non-compacted to compacted myocardium is more than 2.3 to 1. There's prominent left ventricular trabeculations with deep intertrabecular recesses. Prominent left ventricular trabeculation. This is the right ventricle, this is the left ventricle. There is prominent left ventricular trabeculation. Okay, with trabecular hyperenhancement. With trabecular hyperenhancement. Diagnosis left ventricular non-compaction. Common cause of arrhythmia. Left ventricular non-compaction is caused by arrest in the endomyocardial morphogenesis in the embryologic life, resulting in failure of compaction of the subendocardial myocardium to form a spongy to solid. Presentation, arrhythmia, congestive heart failure. Management, medical treatment, anticoagulant, beta blocker. Any case of arrhythmia should receive anticoagulant therapy. Okay. Beta blockers and surgical treatment, biventricular pacemaker to treat the arrhythmia, the ventricular arrhythmia. So the left ventricular non-compaction will lead to ventricular arrhythmia. So biventricular pacemaker is the surgical treatment of choice. Then heart transplantation. Start with medical beta blocker for the arrhythmia, then surgical biventricular pacemaker, then cardiac transplantation as the last resort. So the ambulatory ECG or Holter monitor is to diagnose the most appropriate investigation for episodic palpitation, for paroxysmal or episodic palpitation with normal ECG. This is an example of cardiac pacemaker. How the cardiac pacemaker will appear on the chest X-ray. Pacemaker generator. This is the pacemaker generator. Is commonly placed in the infraclavicular region. So this is the pacemaker generator, commonly placed in the infraclavicular region. It's below the clavicle here. Okay. Lead wires. may vary in number and position, but we have right atrial wire, right ventricular wire, left ventricular wire. So we have 3 wires for the pacemaker. We have I can see here only 2 wires. This is the right atrial wire will be placed medial to the right atrial appendage. The right atrial wire will be placed medial to the right atrial appendage. This is the right atrial wire. The right ventricular wire tip should be near the right ventricular apex. Here, this is the right ventricular apex. This is the left ventricular apex. So I can see here the right atrial wire and the right ventricular wire with its tip near the right ventricular apex. I can see the left ventricular wire, but it's placed in a tributary of coronary sinus or the left ventricular surface, on the left ventricular surface. So the pacemaker placement is the mainstay treatment to treat the arrhythmia. However, the ECG, the resting ECG, and the ambulatory ECG or Holter monitor is the mainstay investigation, the most important investigation. Resting ECG, and if normal with episodic palpitation, then ambulatory ECG or Holter monitor, and the mainstay treatment is the placement of cardiac pacemaker.